Good evening, everyone. Myself, Dr. Mamta, Associate Professor in College of Nursing, AIIMS, New Delhi. Today, we will discuss regarding prone ventilation. Before starting the presentation, let us discuss about the objectives of today's presentation. So, through the today's session, we'll be able to understand the physiological benefit of prone ventilation. We'll be able to identify indications and contraindications for prone ventilation. We'll be discussing regarding the turning procedure that has to be used for turning the patient from prone to supine and supine to prone position. And this session will also help to delineate the comprehensive nursing responsibilities throughout the proning procedure. And it will also help you to identify the complications related to proning. Let's start with the session. Firstly, about the prone ventilation or proning. As the name suggests, it is the method of mechanical ventilation where the patient is placed with the face downward on the abdomen and the chest in a prone position to improve the oxygenation, particularly in case of severe respiratory distress. This technique is commonly used for patients with acute respiratory distress syndrome and can help to reduce the mortality level. So as you can see in the picture, the patient is lying on the chest and on the abdomen with the face and head facing downward while being on mechanical ventilator. So what could be the indications for this prone ventilation? The foremost and the most commonly the prone ventilation is being used in cases of ARDS. So if a patient is having new onset or is having severe ARDS, prone ventilation is recommended. And if the patient has following parameters such as a mismatched ventilation perfusion ratio with partial pressure of oxygen ratio in reference to FiO2 less than 150 mm of Hg, FiO2 less than more than 60% and PEEP more than 5 centimeter of water. Recently in COVID-19 infection, this therapy, prone ventilation, has been used and has been found to be more effective for patients to increase their oxygenation status. This has also been used as a rescue strategy in case of severe hypoxemia. As I told, this is prone ventilation is being used in cases of ARDS. It is very important to understand what this ARDS is. ARDS is an acute diffuse inflammatory form of lung injury and a life-threatening condition in seriously ill patient which is characterized by poor oxygenation, pulmonary infiltrates and acute onset. On a microscopic level, the disorder is associated with capillary endothelial injury and diffuse alveolar damage. The key features for ARDS include acute onset, bilateral lung infiltrates on chest radiography or CT scan of a non-cardiac region with partial pressure of oxygen is to FiO2 ratio of less than 300 mm of Hg. If this ratio decreased down to 100 mm of Hg, we consider it as severe ARDS. The requirement of PEEP or continuous positive airway pressure of greater than or equal to 5 centimeter of water. This prone ventilation was first proposed in 1970 as a method to improve gas exchange in case of ARDS. Lately in 1974, to minimize atelectasis in injured lung, Brian advocated the use of prone positioning, suggesting that it could decrease pleural pressure gradients and re-establish ventilation in dorsal region of the lungs. Then in 1976, PLMA conducted clinical case series which further supported this concept, documenting significant improvement in oxygenation in the prone position. And as I told recently, in the time of COVID pandemic, this therapy has been used in COVID-19 patients, and it has reported that this therapy improves the oxygenation in case of COVID-19 also. Now, how this prone positioning or prone ventilation help the patient to improve their oxygenation status? The improvement of oxygenation during prone ventilation is multifactorial, but occurs mainly by reducing lung compression and improving the lung perfusion. I will try to make you understand this with the help of this picture. Now you can see in the picture, the above two images are showing the patient lying in a supine position. So if you see, the ventral portion or the interior portion of chest is mostly covered with the heart giving less space to the lungs. That means the less space is available for perfusion as compared to the dorsal or the posterior patient. So as shown in figure B, if a patient is having ARDS, in case of the supine position, the fluid will, because of gravity, will settle down in the dorsal portion of the lungs. And the portion which will be available for perfusion will be the ventral or anterior ventral portion of lungs or anterior portion of the heart, which is having less of space for perfusion. If we make the patient to lie in the prone position as being shown in figure C, the dorsal portion of the lungs will be available for perfusion, which is having a larger area available for perfusion. And also because of gravity, the fluid will settle in the ventral portion of the lungs. That in that case, more space in the dorsal or the posterior portion of the lungs will be available for perfusion. That's why it increases the oxygen level within the body if being used in case of ARDS. So what could be the physiological rationale of using the prone position to improve the oxygenation status of the patient? The prone positioning, it enhances ventilation perfusion matching by redistributing the pulmonary blood flow. It promotes the alveolar recruitment in dorsal lung regions. It reduces compression from mediastinal structures, and it also improves the secretion drainage and reduces ventilator-induced lung injury. Now, there are some of the contraindication in which the prone ventilation need to be avoided or should be used carefully. This include suspected increased ICP more than 30 mm of Hg or cerebral perfusion pressure of less than 60 mm of Hg. If the patient is having unstable spine, femur, pelvis, rib fracture or other skeletal limitations, if a person is having open chest or unstable chest wall, substantial facial trauma, substantial acute bleeding, wound at risk of dehiscence, pregnancy, and in case of tracheal surgery or sternotomy where it can be used, but the surgical team should be consulted before its use. Now let us come to our main topic. What should be the responsibility of the health team or the nursing personnel when they are preparing a person to be shifted to a prone position for prone ventilation? So there are some pre-procedural preparation that need to be considered. Firstly, multidisciplinary discussion regarding the potential risk and benefit of prone ventilation need to be considered. Ensure that the patient is having no contraindication for this prone ventilation. Inform and counsel patient and relatives whosoever is appropriate as per the condition. Ensure adequate number of staff is available to facilitate safe procedure. Generally, it is recommended to have minimum 5 staff when we are shifting a patient to the prone position for ventilation, including the anesthesiologist. However, there should be separate person available for taking care of the chest tubes if they are present. Ensure the team has considered any outstanding investigation procedures and necessary transfer that would prove to be difficult to perform once the patient is in prone position. Before shifting the patient to prone position, airway and breathing need to be considered. Keep difficult airway trolley checked and available in case of emergency. Note previous laryngoscopic grades and length of endotracheal tube at the lips. This will help us to know the dislocation of ET tube at the time of procedure. Securely tape or tie the ET tube. If tight, then ensure padding in situ between the tie and the skin. Suction the oropharynx and the airway prior to the procedure. Throughout the procedure, patient should be pre-oxygenated with 100% oxygen and ensure appropriate ventilator settings. Note tidal volumes and inspiratory pressure before procedure to be compared with the post-procedure values. Perform pre-proning arterial blood gas and document the results also. Regarding the cardiovascular system and the lines associated with it, ensure all lines are sutured and secured. Discontinue non-essential infusion and monitoring. Patient should be cardiovascularly stable before shifting to prone position and prepare for post-proning instability with the preparation of vasopressors and inotropes being prescribed. For the neurological preparation, The patient should be receiving adequate sedation and analgesia. Deep sedation is usually recommended with a RAS score of -5. Considered muscle relaxations as per the institutional policy. Bolus dose may be required. For skin and eyes, the nursing staff should document the skin integrity. Eyes should be cleaned, lubricated, and taped to prevent drying and ulceration. Ideally, eyes should be protected with the gel pads or similar items available in the institution. For the other lines, ensure nasogastric feed should be stopped and ensure that the nasogastric tube is aspirated, ideally at least 1 hour before proning. Document the length of NG tube, specifically that is outside the nose, so that you can identify if any dislocation happen at the time of procedure. Chest drains need to be well secured and placed below the patient. Tubing should run down the patient and be managed by a separate team member that should not be included in that 5 members who are taking care of shifting patient to prone position. Clamp only if safe to do. Adequate length of remaining lines or cables running up the patient if above the waist and down if the patient if below. The urinary catheter should be spagotted using a tape and it should be taped to the inside of the leg. Some general precaution measures need to be taken care before shifting the patient to prone procedure, such as daily hygiene need to be addressed, example mouth care, washing, dressing and changing of stoma bags. Generally, when we are shifting a patient to a prone position for prone ventilation, it is recommended to keep the patient in prone position for 12 to 14 hours, and in some cases, we keep the patient in that position up to 16 hours. So it will be difficult for to perform some of the procedures such as mouth care in prone position. So that's why it is recommended that the daily hygiene need to be addressed before shifting the patient to prone position. Ventilator should be placed as close as to the patient on the appropriate side, and whenever we are rolling the patient to prone position, we need to make sure that the patient should be rolled toward the ventilator. Now coming to our main procedure, when we are talking about prone positioning, it requires 2 procedures. Firstly, shifting the patient from supine position to prone position in the beginning of the procedure, and secondly, shifting the patient from prone to supine position after 12 to 14 hours. So firstly, we will discuss the steps how the patient need to be shifted from supine to prone position. So step 1 include the staffing. There should be minimum of 5 people, including 1 anesthesiologist in the team. Team members should introduce themselves in the beginning of the procedure and state their roles so that the team should know that no role is missing, and they should also know which role is being performed by which members so that adequate commands can be given. Anesthesiologist should be positioned at the head end and will be responsible for coordinating the whole procedure. At least there should be 2 other people on either side of the patient, but more may be required depending upon the size of the patient. Additional staff should be allocated for the management of chest tubes, chest drains, ECMO cannulas if in situ. In coming to positioning, that is our step 2, patient should be laid flat with the bed in neutral position on a clean sheet with side sheet beneath. Arm closest to the ventilator is tucked underneath the buttock with the palm facing anteriorly as shown in the image. This will help in turning the position to prone position. Interior ECG electrodes need to be removed. Pillows can be placed over the chest, iliac crest and knees. This should be placed strategically according to patient body habitus to reduce the pressure placed on abdomen. So third step is wrapping of the patient, which starts with placing the pillow over the patient. So whenever we are turning the patient to prone position, these pillows should be below the points to prevent the pressure ulcer or pressure decubitus. So generally the pillows are being placed above the chest, above the pelvic area and above the knees to protect the pressure points. The sheet that is beneath the patient need to be untucked, and then the patient need to be wrapped with the cover sheet. So the team, they need to hold both the cover sheet and the sheet beneath the patient simultaneously so that this can help to minimize the patient dislocation and the pillow dislocation. A clean bed sheet should be placed on the top of the patient, leaving only the head and neck exposed. The edge from the top and bottom bed sheets are rolled tightly together, thereby encasing the patient between the two and keeping the pillows in correct position on the top of the patient, as being shown in this image. Step 4 include horizontal move. Keeping the bedsheet pulled taut and edges rolled tight, patient should be moved horizontally to lie on the edge of the patient. Generally, the patient is moved away from the ventilator. The direction of horizontal move should be away from the ventilator in the opposite direction to which the patient need to be turned. Step 5 include the lateral turn. On the call of the person, which is the head of the team, the anesthesiologist, they count 1, 2, 3, and on the 3 count of the patient, while maintaining a tight grip on the rolled up sheets, the patient is rotated 90 degrees to lie on their side. Staff on either side should be then adjust their hand position on the rolled up sheet so that they now have hold of the opposite edge when compared to the horizontal move. That means the staff whose hands are now at the downside, they will shift to the upside, and those who are holding from the upside, they will now hold from the downside to shift the patient to the prone position. And this next step is prone completion. On the call of 3 from the head person, that is the anesthesiologist who is standing on the head end, the rolled up sheet is pulled up from beneath the patient while the patient is carefully turned into prone position. Carefully support the head and neck and turn the head to face the ventilator the patient is moved from lateral to prone position. Ensure the ET is not hinged and that a carbon dioxide trace is ETT at the lips and review ventilators moved in the beginning of the procedure and ensure 7 is positioning. Ensure the patient is positioned in the center of the bed. Absorbent pad should be placed under patient head to catch all the secretion. Carefully position the patient arm in swimmer position. This involves raising one arm on the same side to which head is facing while placing the other arm by the patient's side. The shoulder should be abducted to 80 degree and elbow flex 90 degree on the raised arm. The position of both the head and arm should be alternated every 2 to 4 hours. The patient should be nursed at 30 degree in a reverse Trendelenburg position. Step 7, the very important step is care of pressure points. Pressure point care. As I said, the patient will be in a position for 12 to 14 hours. The chances of developing pressure sores will be very high. So ensure optimal positioning of pillows tailored to patient body habitus. Pressure areas should be meticulously checked. There should be no direct pressure on the eyes. Ensure the ears are not bent over. ETT not pressed against the corner of mouth or lips. NG tube not pressing against the nostril. Panny should be hanging between the legs with the catheter secured, and the lines and the tubings, whichever are present, should not be pressing against the skin. For this, the pillow positioning plays a key role. So where the pillows need to be placed, it needs to be placed across patient chest, allowing breast to be supported and free from pressure, across the pelvis, ensuring abdomen to be free of compression, under the shins, preventing hyperextension, at ankle and minimizing pressure exerted on patient's knees. Alter height of pillows to ensure that the neck and lower back are not hyperextended, and position pillows in such a way according to patient size and body habitus to reduce risk of overdistension by allowing the shoulder to fall slightly forward of the anterior capsule of the shoulder joint to reduce the risk of brachial plexus injury. In this, the position of bed and mattress is also very important. The patient need to be placed in reverse Trendelenburg position, that is 30 degree head up. This minimizes the development of facial edema and reduces the risk of NG feed refluxing into the airway. Nurse patient on low air loss mattress and check the mattress is working correctly prior to turning the patient into a prone position. About the face, consider use of fluidized positioner to create a channel for ETT to reduce the risk of pressure damage, monitor skin including ear and nose, and ensure the nasogastric tube is not pressing on inner nose or face. Ensure ears are not bent over to prevent any pressure sore over the ears. Now next, when this 12 to 14 hour period is over, we need to shift the patient from prone to supine position. So at that time, what things need to be taken care of? The anesthesiologist and adequate staff with minimum 5 staff should be available. Pre-oxygenate the patient with 100 degree of oxygen. Endotracheal tube and venous line need to be secured. Discontinue all the non-essential infusions. Adequate sedation and muscle relaxation need to be given. Nasogastric feed need to be stopped and nasogastric tube should be aspirated to reduce the risk of aspiration. Chest drains need to be secured. Patient wrapping should be done as described in the previous procedure when we were shifting the patient from supine to prone position. Horizontally move the patient away from ventilator so that the patient can be turned toward the ventilator. Ideally, it should be done in morning, which allow medical and nursing review, daily hygiene, physiotherapy, and usually when the most of the nursing staff is present. What should be the special consideration when we are considering a patient for prone positioning? Firstly, very important to check the ET tube. Check ET length prior to position. Position ET in the middle of the mouth, not compressing the lips. Place dermal pads between ETT cotton ties and patient skin to reduce the pressure from securing the ETT. Monitor the tightness of endotracheal tube cotton ties to reduce the risk of pressure damage. Check endotracheal tube remains at the pre-prone depth. Check endotracheal tube cuff pressure once the patient is in prone position. Have ET carbon dioxide attached to endotracheal tube throughout the procedure to monitor for disconnection of ventilator and from the ETT and dislodgement of this ETT. CVS, that is cardiovascular system stability, need to be monitored continuously. Reattach all ECG monitoring and arterial catheter transducer as soon as possible once prone to enable resumption of hemodynamic monitoring. Ensure availability of vasopressor fluids in case of any hypertension if it develops. Now, there are some of the complications that can develop because of this prone positioning for which the healthcare personnel need to be keen. First and foremost is the pressure source, which is the most cited injury. The reason is in prone position, the pressure point shift to the forehead, chin, chest, iliac crest, knees and toes. Prolonged pressure on these areas, especially with reduced mobility, leads to skin ischemia and tissue necrosis. And there is also difficulty in frequently repositioning the patient. As I told, the patient needs to be kept in a prone position for a prolonged time, and therefore it is difficult to inspect those pressure areas in that prone position, which make a person more prone to pressure sores. The second complication that can happen in this case could be facial or periorbital edemas. The reason could be dependent position of the head and face, which increase the venous congestion. The gravity also promotes pooling of the fluid, especially during the prolonged prone session, which is exacerbated by fluid overload or inadequate facial padding. The another complication that can be seen in this patient could be IV line or endotracheal tube displacement, which may happen because of rolling of patient into prone position that can cause tugging, kicking, or accidental disconnection of the lines. Limited visibility in prone position make it difficult to detect and correct this displacement. This is especially risky with central lines, endotracheal tubes, and nasogastric tubes. Another thing that can happen in case of prone ventilation, that could be cardiovascular instability, as proning can reduce the venous return due to abdominal compression. which ultimately lead to decrease in cardiac output. It affects ventilation perfusion mismatch in unstable patient. Also increase intra-abdominal pressure and intrathoracic pressures. Particularly, it can be a problematic condition in patients with sepsis, hypovolemia, and cardiac compromise. Another complication that is commonly seen in these patients is ocular injury or corneal abrasion. The reason could be direct pressure on the eyes due to improper head positioning. Also, reduced blinking and exposure keratopathy cause dry corneas. Further, increased intraocular pressure can worsen optic nerve perfusion. Another complication that can be seen in this patient could be brachial plexus injury. The reason is incorrect arm positioning, especially if the abducted beyond 90-degree lead to stretching or compression. Prolonged nerve compression result in neuropraxia or permanent damage. Poor padding or malposition of the shoulder girdle can increase this risk. Staph injuries can also be seen, and CRRT, continuous renal replacement therapy. Inflow problems can also be seen in these patients. In some of the cases, we need to discontinue the therapy before the prescribed time. So what are those conditions in which we need to discontinue the therapy? The positive one is the patient improvement. If patient is meeting the pre-established criteria, is showing improvement in oxygenation status, we can discontinue the prone ventilation. Or if the patient is having absence of response, that is, patient is having consistent partial pressure of oxygen and FiO2 ratio deteriorating by more than 20% relative to partial pressure of oxygen and FiO2 ratio in the previous supine session, stop the prone therapy if deterioration occurring 2 consecutive prone sessions. The therapy need also to be discontinued if the patient present with life-threatening deterioration. Complications that may lead to immediate interruption of prone therapy include oxygen saturation of less than 85% on pulse oximetry, or a partial pressure of oxygen of less than 55 mm of Hg for more than 5 minutes when FiO2 was 1, unplanned extubation, endotracheal tube obstruction, substantial hemoptysis, cardiac arrest, or heart rate less than 30 beats per minute for more than 1 minute, systematic blood pressure of less than 60 mm of Hg for more than 5 minutes. Another thing that need to be taken care in case of prone ventilation is what to be done if patient develop cardiac arrest if the patient is on prone ventilation. So you need to inspect for the scenario. If the time permits, we can shift the patient to supine position, but if patient condition and time don't permit, the cardiac compression need to be started in the prone position. So these are my references. The session is open for any query. Thank you so much.